now. And now I'm gonna share screen. There we go. And present. Okay, you can go ahead, Nadежда.
Okay. Hi, everyone. Our group presentation will be about thalassemia. Next, please. Okay, so thalassemia is a genetic autosomal recessive disorder. It is caused by mutations in the DNA. The mutations are on the alpha or beta chains, which make up the hemoglobin molecule. The alpha chain is made up of 4 genes, and the beta chain is made of 2 genes. We get each gene from each parent in the beta chains, and then 2 genes from each parent in the alpha chain. Thalassemia can be classified as either alpha or beta thalassemia. Next, please. Alpha thalassemia results from mutation in the alpha chain. It can be 1, 2, 3, or 4 mutated genes. The more mutations there are, the more severe the disease. Beta thalassemia results from mutation in the beta hemoglobin gene. If only one gene is mutated, the disease is mild, but moderate to severe if both genes are mutated. Thalassemia can also be classified as minor or major, and it can be homozygous or heterozygous. Next, we're going to be talking about alpha thalassemia. There are 4 types of alpha thalassemia. The first one is just the A trait or the alpha trait, which can also be called the heterozygous. It's only one alpha chain forming gene is defective. No symptoms, the person has no symptoms, but they are carrier of the disease. In the alpha thalassemia minor, there are 2 genes that are defective and the person can show mild symptoms. The alpha H disease, which is the 3rd form, has 3 genes mutations or 3 genes that are defective, and the symptoms can vary from mild to severe. And the last one is alpha thalassemia major, and this one has a defective, all the 4 genes are defective, and they can be please. Beta thalassemia. There are 3 types of beta thalassemia that we can talk about. The beta thalassemia minor or heterozygous thalassemia. One defective beta gene, it is mild or severe, and usually the person has a normal life expectancy. The beta thalassemia major or Cooley's anemias is the homozygous form of the beta thalassemia. It has mutations on both of the genes. It can be severe. And we have another form of the beta thalassemia, which is called the beta thalassemia intermediate. This one is moderate. It's not severe as the major thalassemia, but sometimes it may require a blood transfusion. And although the blood transfusions are not required as in the beta thalassemia major, the person may need them just to improve the quality of life. Next, please. The risk factors for thalassemia are mainly a family history of thalassemia, and some people, especially that are from African descent, Mediterranean, Middle Eastern, or South Asian, are more at risk for having thalassemia. And it also says consanguineous marriage, that means marriage between cousins, so we'll classified as family history of thalassemia. Next, please. Okay, so incidence and prevalence of thalassemia. Beta thalassemia is more common and it is usually more severe than alpha thalassemia. Beta thalassemia most common in people from tropical and subtropical regions of Asia, the Mediterranean, and the Middle East. Alpha thalassemia is more prevalent in people from Mediterranean countries like North Africa, Middle East, and India, and also Central Asia. It says that about 5% of the world populations has variation of the alpha or the beta thalassemia, but only 1.7% show signs of the thalassemia trait. Next, please. This other slide shows some of the incidence and prevalence. It's a lot of numbers, but basically it shows that the regions that I already talked about, the Sub-Saharan Africa, Western Pacific, and the Mediterranean, we see that, and also in America, we see that all those, most of the population show the generic traits for thalassemia. Usually the population, or just like a small percent of the population actually has it, but they'll show it in a generic, there will be generic carrier of the disease. Thank you. Next. Differential diagnosis for thalassemia. We have alpha thalassemia versus beta thalassemia. We also have a thalassemia versus iron deficiency anemia. This is because the thalassemia disease it's similar in some ways to iron deficiency anemia because both of them are microcytic hypochronic anemia and they have increased target cells in the peripheral blood. And the beta thalassemia major versus the hereditary persistence of fetal hemoglobin. This is because both disease can produce high levels of hemoglobin F. Next, please.
So going into pathophysiology of thalassemia, beta thalassemia pathophysiology is, as Nadежda mentioned, the autosomal recessive disorder. So it impairs the synthesis of beta globulin change, which causes erythrocytes to have reduced amount of hemoglobin and free alpha chains to accumulate. So when they accumulate, free alpha chains become unstable and they precipitate in the cell. These alpha chain precipitates within the cell are then destroyed by the mononuclear phagocytes in the bone marrow. And the end result of the beta thalassemia pathophys, there's ineffective erythropoiesis and therefore causing anemia. In alpha thalassemia pathophysiology, it often occurs in utero, and these chains do not end up with hemoglobin not being formed at all. And as you can see in the next slide, this hemoglobin, these alpha chains are very important in holding together a hemoglobin molecule. And without the alpha chain coming together, you do have in utero fetal demise, which in the next slide, signs and symptoms of beta thalassemia minor include elevated serum albumin, iron and bilirubin levels, due to hemolysis and immature erythrocytes. You do have mild splenomegaly, bronze coloring of the skin, and hypoplasia of the bone marrow. And beta thalassemia minor, which is more severe than major, which is more severe than minor, you do have more signs and symptoms that occur. So these include impaired physical growth and development. You do have liver enlargement due to progressive hemosiderosis. You do have splenomegaly, which is caused by extramedullary hemopoiesis and destruction of the RBCs. In growth and development, you have spinal impairment that can cause growth impairment, and you have limb deformities. In the end, when it comes to beta thalassemia major, they do receive chronic blood transfusions, which can cause death due to severe hemochromatosis, which is just unhealthy levels of iron within the blood. And again, when looking at alpha thalassemia, which is life-threatening, usually occurs in the third semester of pregnancy, you do have fetal tissue anoxia, which leads to fetal demise. So again, major differences between beta thalassemia major and beta thalassemia minor is just the severity of it. And looking back at alpha thalassemia, it is truly life-threatening to in utero for the fetus. Going to the next slide.
So next we're going to talk about diagnostic tests and labs. So first we would have a complete blood count. It includes measures of hemoglobin and the quantity and size of red blood cells. People with thalassemias usually have fewer red blood cells and less hemoglobin. Those with alpha or beta thalassemia trait may have smaller than normal red blood cells. Next, we would want to do a reticulocyte count, which is a measure of the young red blood cells, which may indicate that your bone marrow is not producing an adequate number of red blood cells. Then we'll do some iron studies, which will indicate whether the cause of anemia is iron deficiency or thalassemia. So iron deficiency is not the cause of anemia in people with thalassemias. Then we would do some hemoglobin electrophoresis, which is used to diagnose beta thalassemia, as well as genetic testing, which can also help diagnose alpha thalassemia. Then we're going to talk about some treatments. So how is thalassemia treated? So the standard treatments for patients with thalassemia major are blood transfusion and iron chelation, as previously stated. So in blood transfusions, they'll get donor red blood cells and they'll inject them through a vein to restore normal levels of healthy RBCs and hemoglobin. So transfusions are repeated every 4 months in patients with moderate or severe thalassemias, and every 2 to 4 weeks in patients with beta thalassemia major. So occasional transfusions may be needed, for instance, during times of infection for hemoglobin H disease or beta thalassemia intermediate. In iron chelation, they remove the excess iron from the body. It's a danger in blood transfusions as they can cause iron overload, which may in turn cause damage to other organs. Because of this, patients who receive frequent transfusions also require iron chelation therapy, which can be given in a pill form. It's also important to monitor nutritional supplements. So they could be taking folic acid supplements and B12. And then finally, one really good treatment is bone marrow and stem cell transplantation, usually from a compatible donor. Most patients with thalassemia, however, lack a suitable sibling donor. So a bone marrow transplant is done in hospital. Within 1 month, the transplanted bone marrow stem cells will start to make new healthy blood cells. Given the high risk of bone marrow transplant, it is not routinely recommended for those with mild or moderate thalassemia. So evidence-based practice, we're gonna talk about, there's some hypersplenism. So hypersplenism causes a marked increase in transfusion requirements. So splenectomy may be needed. Surgery is usually delayed until at least 4 years of age because of the spleen's role in clearing bacteria and preventing sepsis. So children should also receive the pneumono conjugate vaccine series and then antibiotic prophylaxis with penicillin twice a day is recommended for all persons during the first 2 years after surgery and for children younger than 16 years. And then finally, we're going to talk about some pharmacogenetic considerations. So according to the Journal of Cytology and Histology, there's some patients who respond to certain drugs, and then at the same time, some patients manifest different side effects. The exact reason behind differential clinical response for any drug among thalassemia patients is still under research. Population-specific genome studies have already delivered some results about this aspect. There are very few reports so far available for the usefulness of pharmacogenetics in treating thalassemia. Researchers are now trying to find out the association between drug efficacy and genotype of patients. Study on pharmacogenetics will help in the future development of personalized medicine for thalassemia. And then next, Maggie is going to talk about prognosis.
So thalassemia's prognosis for mild patients, they can have a normal life just under the treatment. For moderate or severe people, that means HB less than 5 to 6 gram, need to follow treatment program. And also because of heart disease from iron overload is the leading cause of death. So patient need to keeping up with their iron chelation therapy. So also bone marrow transplant can cure the thalassemia, and also maybe some patient need to do the surgery to correct a skeletal problem. Next one. For the thalassemia nursing plan, The major diagnosis is risk in is the ineffective tissue perfusion and activity intolerance, and also risk of bleeding. Next one. And nursing care goals. Patient will mobilize using the energy conservation, and also mobilize reduction of fatigue, and patient will have reduce the risk of infection, and also reduce risk of bleeding. Next one. And nursing intervention for ineffective tissue perfusion assist the local or symptom sign of infection, instruction the patient to avoid contact with people already got sick, and also instruction the patient to avoid eating raw food, just like raw fruit, vegetable, or uncooked meat. Stress the importance of daily hygiene, like just like a mouth care or and hand washing. Next one. And for activity intolerance, assist the patient do the daily activity plan, and assist the patient in developing a schedule for daily activity and rest, and stress the importance of frequent rest periods. Next one. For the risk of bleeding, assist of any frank bleeding from the nose, gums, vagina, or urinary or gastric tract. Also monitor the platelet count, and also teach patient use the soft teeth brush to wash the mouth and avoid the body contaction sports, just like a football or basketball, just like this. Okay, so I think this is the end of presentation. Thank you. There's a reference, yeah.